Il y a 2 tantes paternelles cancer du sein, 45 et 65 ans. À l'examen clinique, il y avait une douleur intense au niveau des cervicales, thoraciques et qui descendait jusqu'au bassin. Cliniquement, il n'avait rien à la palpation et elle avait un bon volume mammaire. Elle était donc sous thérapeutique antalgique depuis 6 mois et traitée de dépressive. Après plusieurs allers-retours aux urgences, il a été réalisé un scanner corps entier et a été donc retrouvé des métastases osseuses lithiques de la voûte crânienne jusqu'au bassin, avec une fracture de la 3e cervicale et de la 8e vertébrale, et a été découvert. Alors je mentionne que celle qui a interprété le scanner est une radiocénologue, et je lui rends, enfin, c'est le docteur Asma Bekouche, et qui a dit, mais il y a aussi une image anormale dans le sein gauche. Et donc, elle nous a été référée le 15 mars pour prise en charge. Donc, vous voyez ces images très spectaculaires où on voit ce rachis qui est mité de bas en haut et avec un risque, donc un examen neurologique normal et une fracture instable de la 3e cervicale avec, vous voyez, un risque médulaire majeur et ainsi qu'une fracture de la 8e. Donc, elle a été... Alors, on va commencer tout de suite par les questions pour quelle est votre première décision? Est-ce que vous explorez le sein? Est-ce que vous faites un TEP scanner? Est-ce que vous immobilisez et référez à un spécialiste du rachis? Ou est-ce que vous faites une chimiothérapie en urgence? Donc, il n'y a pas d'interaction, on va passer directement à la question. L'immobilisation est référée au centre du rachis et l'urgence absolue pour cette jeune femme, parce que si elle devient tétraplégique, elle vivra avec son cancer et elle sera malheureusement handicapée à vie. Donc, l'urgence, c'est l'immobilisation du rachis. Donc, tout de suite, elle a été prise en charge par nos collègues pour une stabilisation du rachis cervical. Vous voyez la 3e vertèbre totalement détruite, et afin de prévenir un risque de complications neurologiques et traiter ensuite les douleurs dorsales attribuées à la fracture de T8. Donc, le traitement chirurgical a consisté à une corporectomie, donc c'était par une voie antérieure, à une corporectomie de C3, une fixation de C2, C4 par cervicotomie, et ensuite, elle a eu une cimentoplastie percutanée de T8 qui ont immédiatement soulagé ces douleurs rachidiennes. Et puis, nous avons fait secondairement donc, le bilan mammaire avec donc la mammographie, ce surcroît d'opacité centré sur des petites calcifications, l'échographie retrouvée donc une formation hétérogène irrégulière de 2 cm dans le cadran supérieur externe du sein gauche. Donc, what initial check-up do you need? Donc, TEP scanner, IRM mammaire, consultation oncogénétique, multidisciplinaire meeting. Et donc, l'ensemble des réponses est importante. Ce n'est pas une décision qu'on prendra de manière unilatérale. Et donc, il y a un bilan check-up initial, l'oncogénétique du fait de sonnage et les décisions partagées. What is therapeutic choice and sequencing? Donc, est-ce que vous commencez...
Séverine,
oui.
Séverine, excuse-moi, je t'interromps. Ça fait depuis le début de ta présentation, on essaie de t'informer. Les diapositives ne sont pas, ne passent pas, ne s'affichent pas.
Ah mince!
Tu dois partager ton écran.
Eh bien, je l'ai partagé. Ah mince! Ok, parce que alors, les images, pour le coup, sont spectaculaires. C'est dommage. Alors, je partage. Là, est-ce que vous les avez?
Non. On te voit seulement.
Eh oui, mais alors je partage l'écran. Ah, parce que moi, j'étais à fond dans le topo, comme vous l'avez vu.
J'ai ta présentation, Séverine. Si tu veux, tu me demandes de faire la suite.
Alors, ça y est, ça apparaît, je crois.
Ça, c'est moi qui partage ton écran.
Et là, regarde. Là, j'ai mis partager, que j'avais fait quelques modifications.
Ça ne passe pas.
Et les 2 premières sont bien passées. Pourquoi ça ne passe pas? Là, vous les avez?
Tu veux que je fasse passer ta présentation?
Écoute, s'il n'y a pas d'autre alternative, parce que je partage, il n'y a rien qui vient.
Tu vois notre écran, là?
Non. Moi, je ne vois pas votre écran. C'est un écran noir. Là, vous n'avez pas accès à l'écran. Ah, là.
là.
Là, vous avez l'écran.
Ok, tu peux contrôler l'écran dès maintenant. Ok, tu peux contrôler notre écran.
Donc ça, c'est le vôtre? Oui, d'accord.
Le nôtre.
Ok, parfait. Et donc, voilà, là, c'était...
Les métastases osseuses.
Je le contrôle comment? Par... Comment je le
cliques tu cliques sur l'écran. Voilà.
Ok. Donc, on a été, voilà, vous voyez cette destruction complète de ces trois. Et donc, stabilisation du rachis et prévention, pour une prévention des complications neurologiques. Voilà, donc ça, on l'avait fait. Donc, l'urgence est au rachis. Et ensuite, on s'intéressera au sein. Donc, ouais, j'avais fait des modifications qui n'apparaissent pas, c'est dommage. Donc, ça, c'est la lésion mammaire. Hein, donc, on retrouve secondairement cette lésion localisée dans le cadran supéro-externe. Et donc, la stabilisation du rachis avec une corporectomie complète de ces trois, une néo-vertèbre stabilisée sur celles qui tiennent au-dessus, en dessous. Le check-up, comme je vous disais, ça, c'était les 4 sont nécessaires. Faire un bilan d'extension complet, revenir sur l'imagerie mammaire, avoir une consultation oncogénétique et un staff multidisciplinaire. Donc, quel premier traitement initiez-vous? Est-ce que vous partez d'emblée sur une chirurgie du sein? Est-ce que vous débutez par une chimiothérapie néoadjuvante? Ou est-ce que vous faites une endocrinothérapie avec anti-CD4/6 et puis ensuite chirurgie selon la réponse? Donc là, ah, il y a les couleurs. La bonne réponse était la réponse C, hein, patiente métastatique, surtout pas de chirurgie en premier. Hein. Donc elle était RH positif, HUR2 négatif, et donc elle a eu, on va le voir après. Donc la décision multidisciplinaire a été donc de traiter l'os, de faire une radiothérapie sur les différentes vertèbres les plus touchées et à risque fracturaire, d'arrêter immédiatement l'androcure et d'initier agoniste à l'HRH, anti-aromatase et palbociclib. Donc le 24 septembre, elle est revue, elle était nettement soulagée de ses douleurs par les différentes thérapeutiques. Le palbo, malheureusement, après plusieurs tentatives, a dû être arrêté au bout de 2 mois en raison d'une leucopénie profonde. Et à l'évaluation radiologique, il y avait une réponse de 50%. Il n'y avait plus de lésions palpables et donc a été programmée une chirurgie conservatrice du sein avec pose de maxide en intratumoral et un ganglion sentinelle isotope. Donc là, vous avez au niveau histologique, la petite lésion avec le maxide à l'intérieur et donc on va s'en servir au bloc pour le repérer. Donc sur la pièce opératoire, vous aviez le coil donc initial avant la chirurgie et donc il s'agissait après donc hormonothérapie néoadjuvante, donc petit y, petit p pour néoadjuvante pathologique T2N1 R0. La taille résiduelle c'était 25 mm, donc on était loin d'une réponse complète. Des marges saines à plus de 4 mm et un Ki67 à 10%. Donc, quelle décision prenez-vous après l'intervention? Est-ce que vous réopérez la patiente? Est-ce que vous faites une radiothérapie creux et axillaire et sein? Est-ce que vous arrêtez l'hormonothérapie? Est-ce que vous faites une chimiothérapie adjuvante? Donc, la réponse était radiothérapie et puis ensuite poursuivre l'hormonothérapie entreprise au départ. Et donc, elle a eu... Alors, et le ganglion, oui, je pense que il y avait en fait une atteinte axillaire. Hein. Donc, il n'a pas été décidé de la réopérer, mais de faire une irradiation sein et sel, et puis de poursuivre anti-aromatase agoniste et d'adjoindre le denosumab, donc les biphosphonates. Donc, évolution. En juin, il y avait une évolution favorable. Avait été introduit le fulvestrant, l'abemaciclib et le denosumab. En novembre 2022, cette jeune patiente donc, a fait une évolution métastatique. Elle a été, donc le Taxol a été introduit avec un relais exemestane sur 6 mois. Et donc, aux dernières nouvelles, et même en septembre 2023, elle est stable au niveau hépatique et osseux et contrôlée donc, par les thérapeutiques ci-dessus. Donc, métastase osseuse, quelle est la place de la chirurgie du sein et des ganglions? Donc, il y a plusieurs études rétrospectives. 15 suggèrent un bénéfice à un traitement loco-régional. Il y a des essais prospectifs qui sont pour l'instant négatifs en cours. Et il y a une Cochrane database de mars 2018 qui retrouve, donc qui liste les différentes études en cours avec le nombre de patientes et quand il y a eu chirurgie ou pas chirurgie, et on voit qu'il y a effectivement un effet mineur de la chirurgie locale sur des patientes métastatiques. Voilà, ça c'est les essais actuellement prospectifs. Donc un de gros essais est à Montbé, au Tata Memorial Hospital, qui inclut 350 patientes et avec donc métastase osseuse et qui est pour objectif primaire donc d'étudier la survie globale. Ensuite, il y a des essais au Canada, en Europe, en Autriche et au Japon. Donc ça, c'est l'essai, donc c'est le Tata Memorial Hospital à Bombay. Donc c'était des cancers du sein d'emblée, vierges de tout traitement, qui avaient moins de 65 ans, avec une espérance de vie de plus de 1 an. Elles étaient des tumeurs résécables d'emblée et RH positif. Et puis ensuite, il y avait des tumeurs non résécables qui avaient été en chimio néoadjuvant, donc 350 patientes, dont dans le bras expérimental, si on fait un traitement loco-régional de la tumeur primitive, et dans l'autre bras, on ne fait pas de traitement loco-régional. Donc pour l'instant, il n'y a pas d'évidence d'une supériorité de l'un par rapport à l'autre. Et c'était des stratifications randomisées selon le site de la métastase, le nombre de métastases et le statut hormonal. Donc, voilà, confirme pour l'instant, voilà, la chirurgie ne semble pas transformer le pronostic local des patients. Donc, quelques messages clés. Tout d'abord, par rapport à la prise en charge osseuse, je crois que nous, en tant que médecins, quelles que soient nos spécialités, il faut être extrêmement vigilant sur la douleur et prendre en charge immédiatement cette douleur, en particulier s'il y a un risque fracturaire et donc traiter localement et en cas de compression médulaire. Donc la place du traitement loco-régional selon donc notre référentiel national français, soit donc la maladie métastatique est stable ou évolutive mais symptomatique et on peut espérer une amélioration de la qualité de vie. La décision se fait au cas par cas, donc en staff multidisciplinaire et avec la patiente. Et quand il y a une chirurgie, il faut être au maximum conservateur et, si possible, en marge saine. Il n'y a pas de données scientifiques évidentes sur la place d'une chirurgie axillaire, donc on essaie d'éviter pour ne pas grever la qualité de vie, en particulier ne pas générer un lymphœdème qui est extrêmement, qui serait extrêmement pénalisant pour la patiente. Ensuite, quand il y a une chirurgie conservatrice, effectivement, c'est place de la radiothérapie post-opératoire. Alors, je crois qu'il y a des radiothérapeutes dans la salle, donc vous avez aussi un point de vue. Et ensuite, il y a toujours une option qui doit être discutée pour le loco-régional, c'est partir sur une radiothérapie exclusive. Et donc là, ça se fait au cas par cas. Donc, par rapport, les diapos sont après donc un bilan exhaustif de la cartographie des lésions osseuses IRM. Peut-être aussi discuter les biopsies osseuses pour voir si c'est la même lésion histologique que le sein, parce que parfois on peut être étonné de trouver une hétérogénéité tumorale, en particulier s'il y a des récepteurs HPR2 surexprimés. Et on va discuter au cas par cas donc l'acide zolédronique en cas d'hypercalcémie, de métastase osseuse et de durée de traitement. Il y a bien évidemment un check-up dentaire à réaliser. Ce sont des traitements d'une durée de 2 ans, avec au minimum toutes les 4 ou 8 semaines. Et après 2 années, se discute un espacement, donc des injections d'acide zolédronique. Donc, pour optimiser le traitement loco-régional et systémique, il faut impérativement intégrer la qualité de vie de ces patients dont le pronostic vital est quand même peut-être engagé. On sait bien que les patients qui ont des métastases ne sont vraiment pas, on va dire, condamnés. Il peut y avoir des durées de vie de plus de 25, de plus de 10 à 25 ans, à condition donc qu'il n'y ait pas de fracture, qu'il n'y ait pas de paraplégie, qu'il n'y ait pas de tétraplégie. Donc toujours penser à cette qualité de vie pour ces patientes-là. Et je vous remercie pour votre attention et reviens sur sur le bassin méditerranéen. Et je pense que vous, chacun dans votre pays ou vos régions, vous avez aussi ces cas dramatiques de jeunes femmes qui ont, on va dire, et le cancer du sein et d'autres symptômes associés. Le cancer du sein métastatique est est un vrai défi pour nous tous. Et l'enjeu ne se situe pas forcément dans le sein, en particulier au tout début de la prise en charge. Merci beaucoup.
Merci, docteur Séverine. On va enchaîner rapidement à la dernière présentation, qui est un peu en retard. J'appelle le docteur Akila Lazieri. Pour physical activity and nutrition for breast cancer patients, key points in 2022. C'est la 15 minutes.
Non, vous avez dit.
J'imagine que je fais pareil. Ou...
Alors, partager. Tu avais envoyé.
Oui, elle a été envoyée. Est-ce que ça va réussir? Je pense qu'il va faire la même chose. Ok. Alors, bonjour à tous. Donc, le docteur Akila Lazieri, je travaille à Saint-Joseph avec le docteur Séverine Alran et je m'occupe surtout des femmes post-cancer du sein en hormonothérapie. Moi, ce que je voudrais vous présenter aujourd'hui, ça serait plutôt le recentrement sur la place de l'activité physique dans la prise en charge du cancer qui prend de plus en plus d'importance. Alors, comment je fais? Celle-ci?
Non, on le laisse.
Est-ce que vous m'entendez? Est-ce que ça, c'est bon? Ok. Oui, ça se partage déjà. Voilà. Ok. And the characteristics of the physical activity is type, intensity, and frequency. La diapo suivante. Ah, super. What about adapted physical activity? The adapted physical activity, getting people moving when their physical, mental, or social condition prevents them from practicing a physical activity under normal conditions. A physical activity will be adapted to consider the specificities related to the patient and disease and the treatments. sporting activity. Bon, we know what is, je passe rapidement. What is about sedentary lifestyle and physical inactivity? In France, for example, 14% of adults are inactive. It's the fourth leading cause of global death, and it's responsible for 21 to 25% of breast and colon cancers, 27% of diabetes, and 30% of heart disease. And WHO recommendations are 30 minutes per day, 5 days, and 5 times a week. And the intensity will be moderate to intense. The expected effects is improved cardio and respiratory capacity, strengthening muscles, balance, and flexibility. When we lose 1.3 kilo of muscle mass, it's early and progressive sarcopenia. And when we have plus 2 to 4 kilo within 2 years of diagnosis, and with a BMI superior over to 25, overall and the specific excess mortality pre and post-menopause. Physical deconditioning and loss of opportunity. This adjustment to effort and reduced physical performance involves all organs, cardio, respiratory, and musculoskeletal systems. There is a strong amplifier of vulnerability, deterioration of self-image, and deterioration of quality of life. And decrease in practice from the onset of diagnosis and during treatment with negative impact on quality of life of survival, increased toxicity of chemio and radiotherapy, increase in care costs, length of stay, and decreased efficacy of treatment. How does it work? Maintain a BMI, reduce body fat, increase muscle mass, and improve cardiorespiratory capacity. Cytokine and adipokine decrease in pro-inflammatory cytokine like IL-1, IL-6, TNF-alpha, insulin, and leptin, and increase in adiponectin, anti-inflammatory, pro-apoptotic, and anti-proliferative. And the effects on the hormone: reduced estrogen secretion in postmenopause, physical activity increase the secretion of sex hormone binding globulin and decrease the availability of circulation estrogen. The effect from the first session and lasts around 36 hours or even 72 hours, and duration extended by practice session over 6 months. About insulin, insulin is a tumor cell growth factor. It's an anti-apoptotic and reduced SHBG secretion, and it stimulates production of aromatase. And physical activity improves insulin sensitivity, increase of glucose consumption by muscles for 24 to 36 hours, decrease secretion of insulin growth factor and inhibitor of apoptosis, and regulates insulin resistance. It's a link between increase of insulin levels, increased resistance, and breast cancer. What is about the fatigue? It reduced fatigue levels by 18% during treatment, 37% after treatment, proven in breast, colorectal, and lung cancer. Does effect increase the benefits associated with increased practice? Greater benefits for patients who have started physical activity from the start of treatment. Donc en fait, plus on commence tôt l'activité physique dès l'initiation du traitement, plus les effets bénéfiques sont rapidement vus. About quality of life, improvements in patient quality of life in the following dimensions: physical, like managing cancer-related symptoms and treatments; psychological, in self-image; social and spiritual, whatever the cancer diagnosis is, type, stage, and treatment. And improved fatigue and quality of life, certes, but also anxiety and depression symptoms, sleep disorders, cognitive disorders, treatment tolerance, joint and or muscle pain, and weight control. About lymphedema, reduced risk, if there's a sentinel lymph node, 17% at least, and the risk factors are axillary radiotherapy, obesity, weight gain after treatment, trauma, infections, and operated upper limb. 11 randomized studies with 458 patients post-adjuvant treatment, mean age 56.8 years, resistance or not resistance exercise versus usual activities. On va constater dans ce cas-là significant reduction in arm volume, significant improvement in symptom, pain, heaviness and weakness, never harmful, and no increased risk, no increase in pre-existent lymphedema, and short and progressive exercises in terms of intensity and duration. Juste pour revenir sur ce tableau, ce qu'on va remarquer, c'est quand même une baisse de la mortalité, quel que soit le cancer, et ça sera la mortalité globale, la mortalité spécifique et puis le risque de récidive. Notre rôle à nous, du coup, ça serait vraiment d'insister sur l'activité physique comme faisant partie intégrante du traitement, avec la chimiothérapie, la chirurgie, l'hormonothérapie. Les patientes, elles sont vraiment à l'écoute et les effets secondaires, ils ne sont pas tolérés de la même manière quand, quand les patientes, elles sont dans une activité physique et qu'elles ont un programme d'activité physique et qu'elles sont suivies pour cette activité physique de manière régulière que les autres patientes qui sont hors ce standard-là. To conclude, to be integrated into the care pathway from diagnosis onwards, 3 positive effects. Improves vital prognosis, reduces the risk of recurrent, and improves quality of life. And the role of the Mediterranean doctor play an essential role in prescribing and information. Et donc, en fait, en Méditerranée, mais j'ai envie de dire que c'est partout dans le monde, notre rôle, c'est quand même d'attirer l'attention sur l'activité physique qui est probablement très négligée devant l'arsenal thérapeutique qu'on a à proposer à nos patientes. Et surtout d'encourager, dans les pays dans lesquels ça se fait, le remboursement et la prise en charge de l'activité physique comme un outil médical. Okay. For clinical cases, you see Mrs. S, aged 49 for consultation. She weighs 73 kilograms and 1.65 meter tall. She is the mother of 3 children aged 13, 12, and 10 respectively, whom she breastfed for the first 8 months. Mrs. S has been describing troublesome hot flushes and night sweats for 6 months. She hasn't had her period for 13 months after 2 years of regular cycles. She thinks she's gone through menopause. She does not drink alcohol, smoking 25 cigarettes, and Mrs. S has worked her entire career as a laborer in a carpet marketing cooperative. Mrs. S is concerned about a possible risk of breast cancer, as her neighbor has just died for a breast cancer. You discussed her cancer risk factor and preventive measures with her. Which of the following are risk factors for breast cancer in Mrs. S? Late age at first pregnancy, low purity, alcohol, overweight, and lack of physical activity. Wow. C'était les trois qui ont été éliminés. Alors, late age at first pregnancy, overweight, and lack of physical activity. She asks you about the effectiveness of the breast cancer screening program. How do you evaluate the effectiveness of a breast cancer screening campaign? The rate of women taking part in the screening program, the number of new cases of breast cancer diagnosis, increased survival after breast cancer, a reduction in breast cancer mortality in the target population, and a reduction in the prevalence of breast cancer. You discuss with Mrs. S in the primary cancer prevention measures, which consist of stop smoking, limit sun exposure, systematic cervical smear, nutritional advice, and mammography. Je rappelle que la patiente, elle a 49 ans. Donc voilà, c'est le tabac, le soleil, surtout dans les pays méditerranéens, et puis la nutrition qui est un facteur important. Notamment le régime méditerranéen qui est très, très recommandé. Pour la quatrième question, Mrs. S, aged 49 and weighs 73 kilograms and is 1 meter 65 meters tall. Given that she is moderately overweight, you remind her of the WHO nutritional recommendation for cancer prevention. Practice physical activity for at least 30 minutes a day, 5 days a week. Limit the consumption of calorie-dense foods. Increase and vary the consumption of fruits and vegetables. Limit the consumption of red meat and avoid cold cuts. And do not consume more than 5 glasses of alcohol per week and no more than 2 glasses per day. Have alcohol-free days in the week. Sans surprise, hein. Donc l'activité physique régulière, tout ce qui est sucre rapide notamment, qui sont pourvoyeurs de synthèse d'insuline, et ensuite avoir des fruits et légumes. Et bon, la dernière question, c'est que souvent on a été amené parfois à dire que l'alcool avait quand même un effet bénéfique sur l'appareil cardiovasculaire, ce qui tend un petit peu... Aïe. Bon, on m'a changé le truc. On clinical examination, bon, je pense qu'on est parti un peu trop en arrière. Non, pas en arrière, c'est pas grave. Obesity is a risk factor of contralateral breast, high blood pressure, gonadotrophies, fertility problems and depression. Bon, sans surprise non plus, hein. L'activité physique et la nutrition sont très importants et c'est le socle sur lequel on va venir amener la maladie néoplasique et les traitements qui vont avec. La résistance des patients, que ce soit sur le plan psychologique, que ce soit sur le plan cognitif ou le plan physique, va être conditionnée par l'équilibre physique, l'équilibre nutritionnel, mais aussi l'équilibre psychologique des patients et des patients. Là, par rapport à son syndrome métabolique, on avait, je pense, un IMC qui était à 31 avec une hypertension. Les bilans qu'il faudra prescrire justement pour la surveiller sur le plan métabolique. C'est vrai que la plupart du temps, on va être amené à prescrire régulièrement les triglycérides, le cholestérol total, les HDL et les LDL cholestérol. Ce qu'il faudra surveiller, ça sera surtout les triglycérides, les HDL, et puis ça va être le diabète qu'il va falloir guetter très rapidement, qui peut être dû aussi, qui peut être secondaire au traitement par chimiothérapie. Et donc, in the current situation, Mrs. S is at risk of worsening her obesity because il y a une réponse qui est fausse ici, et donc sans surprise, c'est la première, hein. C'est la chirurgie récente qu'elle a eue qui ne va pas is preventing her from resuming physical activity. Je crois que c'était la dernière question. Et je vous remercie beaucoup et désolée pour... on ne vous entend pas en fait et on ne vous voit pas non plus. C'est très perturbant. les autres.
Donc, il n'y a pas d'interaction. Je ne suis pas certaine. Est-on écrit? Ouais.
Vous nous entendez? Merci à tous. À plus tard. C'est vous qui c'est écrit. À plus tard. Merci à tous. À plus tard. Ah oui, rien.
response. She relapsed in 2016. She presented refractory cough. The imaging showed BRCA mutation, because we have 20% of male with breast cancer have this mutation. So the testing in this patient showed the presence of BRCA1 mutation that was detected, and it was deleterious. It was not a VUS. So many times we have the mutation. It's important to see if it's benign, of unknown significance, or really pathogenic or deleterious. So in this case, it's deleterious. That's mean that it's the cause of the breast cancer. What about the guidelines of NCCN regarding the screening and the prevention in patients harboring this mutation? So first of all, the breast awareness remain an important point. Also, the clinical breast examination starting the age of 25 is important. What about the mammogram? The mammogram can be done in young patients. However, if we don't have an MRI, because starting 25 to 30, the primary test for patients harboring the BRCA mutation is the MRI. And starting the 30 years old, we can use the mammogram as the second option to do 6 months of follow-up with MRI and 6 months with the mammogram. The place of chemoprevention is still not conclusive. We have limited data on the benefit of using chemoprevention in BRCA mutated women. And the place of risk-reducing mastectomy is important. We should discuss with the patient the degree of protection, reconstruction options, and the risk. So the risk-reducing mastectomy can be an important option. Some schools, they will push to do it. Others will give the chance to the woman to decide if we can do it with a close follow-up. So this is a really important question of oncogenetics, and it should be discussed with the patient in many sessions, probably with the presence of psychologists and also the genetic counselor. What about the screening and prevention for ovarian cancer? We should know that the detection of ovarian cancer in women having the BRCA1 mutation is at an earlier age, 35 to 40. The BRCA2 is at 40 to 45. And here we should discuss the projet parental of this woman, if she wants to have children or not, to discuss when to do this surgery. Also, the combination of the ECHO plus the CA 125 is really of uncertain benefit, but in certain cases where we don't want to do the surgery for familial issues, we can discuss this technique every 6 months, but it's not really recommended, and we don't have really important data on it. Also, the ESMO guidelines are discussing the initial counseling and the follow-up of BRCA mutation carriers, and this is a paper published in 2020, is one of the clinical practice guidelines of the European Society of Medical Oncology. So in this case, discussion with individuals should address issues of quality of life and psychosocial impact of risk-reducing intervention. For individuals above the age of 25 years from a family known to harbor BRCA1/2 mutation, until mutation status has been assessed, or in women declining genetic test, because many women will say we will not do this test, or risk reduction measures, screening recommendation as for known mutation carriers. So it's important that patients that didn't have the test and the patients who didn't do the surgery should be follow up as patients harboring this mutation. What is also mentioned in the ESMO guidelines is really similar to the guidelines mentioned in the NCCN regarding the risk reduction surgery for breast and for ovarian and also for screening. Another important place of the testing, the genetic testing, was a guideline statement by the 5th ESO-ESMO International Consensus Guidelines for ABC. And here clearly there is a place for germline mutation and not still for somatic mutation. The difference between them that the somatic mutation is detected on the biopsy on the tumor, while the germline mutation is detected on the blood test. So in this case, all the studies showed, and we have a consensus on the importance of germline testing. Also, only germline mutation have proven clinical utility and therapeutic utility. We have 100% consensus on it. Also, another point, we are not only testing BRCA1 and BRCA2. Today, we should test a panel of genes. We have some panels of 25, some panels of 125, but in this case, it's important to see every mutation detected, how we should manage it, and how we should take care of the patient harboring this mutation. And this is becoming more and more difficult because the BRCA mutations maybe in the next few years will be detected when we have an important database in a different way, because every mutation can impact the phenotype in a different way. So in 2023, this patient had a second relapse. The patient reported recurrence of a chronic cough and abdominal pain. Imaging showed multiple bilateral pulmonary nodules and 3 liver lesions. So the summary of the case, 2014, we had this triple negative breast cancer of 1.8 centimeter with positive nodes. She received neoadjuvant treatment for AC4T with partial mastectomy, axillary lymph node dissection, and radiation therapy. In 2016, the first relapse, it was one lesion that appeared in the lung of 1.2 centimeter, surgery, then a follow-up. In 2017, she had the genetic counseling and we detected the BRCA1 mutation. In 2023, the patient relapsed on multiple bilateral pulmonary nodules and several liver lesions. And she was considered as metastatic triple negative breast cancer. Here, the first reflex that we should have in triple negative breast cancer is in the metastatic setting. In the early setting, the PD-L1 is not an important scoring system because all the patients will benefit in the neoadjuvant setting of pembrolizumab. However, in the metastatic setting, the PD-L1 should be done because it's divided based on PD-L1 more than 10%. Those patients will benefit more from immunotherapy. So the PD-L1 was positive in this case, and the patient had a CPS of 17. So the management of triple negative breast cancer today in 2013 will depend from the PD-L1 status, the BRCA mutation, if it's present or not. And today we have an additional biomarker, which is the HER2 low, which means the HER2 1+ or the HER2 2+ with the negative FISH test. All those details and the explanation of the management of triple negative breast cancer will be presented by Professor Fadi Nasser. So also it's important to know when we have the BRCA mutation, we have very interesting trial, the Olympiad study, where patient harboring the mutation, germline mutation of BRCA, BRCA1 or BRCA2 with many prior chemotherapy, we randomized 2-to-1 to receive olaparib or the physician choice of chemotherapy, capecitabine, eribulin, or vinorelbine. And you can see clearly that we have an advantage in progression-free survival of olaparib, the PARP inhibitors, compared the standard therapy, 7 months versus 4.2 months. An important point is that patients who didn't receive chemotherapy and started with PARP inhibitors will have, as subgroup analysis, better results compared to patients who already received many lines of chemotherapy. Also, another PARP inhibitor, the talazoparib, a similar study designed, the UMBRACA study. Also, in this case, talazoparib versus physician choice of chemotherapy. We had an advantage in progression-free survival, 8.6 months versus 5.6 months. And also, if we see the subgroup analysis, we have more advantage in patients who are treatment naive compared to patients who received many lines of chemotherapy. An important point is the Keynote 355, the place of immune checkpoint inhibitors in the metastatic setting. As I mentioned, it's important to know that patients with CPS more or equal to 10 will benefit the most from the immunotherapy, with an advantage of 7 months in overall survival. So it's really a good option. Those patients were receiving only chemotherapy. Today we have many new options that change the management of triple-negative breast cancer. You can see here when the CPS is more than 10, we have better results compared to the CPS more or equal to 1 or all the comers. My last question will be, what is the best treatment sequence in our patient? Here we have a metastatic triple-negative breast cancer, BRCA mutated, PD-L1 more than 17. You will start with PARP inhibitors, or you will give those patients chemotherapy plus pembrolizumab, followed by PARP inhibitors. If you can vote, please. They can't vote. Okay, so Professor Nasser, what is your comment for this debatable point? I have the right to reuse it. This was my question also. So we are dans l'embarras du choix. So you will use the pembro chemo as second line, or we can't use it only in first line. So that's why we started with PARP inhibitors, as you mentioned, but I don't know if you lose the chance of immunotherapy in this patient. It's a debatable point. So let's discuss if you have any questions. Thank you very much.
Donc, les trucs négatifs actuellement, vous allez voir, je vais vous planter un peu sur le PIB, beaucoup de questions qui ne sont pas encore résolues. Donc, je vais reparler comme tu as dit, tu as facilité mon propos. On va voir, on a beaucoup de questions. Je vais mettre la dernière slide, qu'est-ce qu'on est en train de faire dans l'ensemble du monde, même si on n'a pas la preuve jusqu'à présent de ce qu'on fait dans le pays. D'autres questions? Donc, on entame avec les triples négatifs. Donc, moi, je vais parler là aussi de triples négatifs, mais je ne vais pas parler de métastases comme la plupart de l'audience ne sont pas des oncologues. Donc, je vais parler comment on pense avec une malade quand on discute avec le docteur Alban.
Donc, donc, les slides sont en anglais, ma présentation sera faite en français. Donc, je vais parler d'un cas qui est de triple négatif aussi, d'un cancer du sein, pour mettre un peu les questions qui se posent actuellement dans les triples négatifs des cancers du sein. C'est une jeune femme qui a 36 ans. Donc, on découvre chez elle un cancer du sein. Elle avait sa mère qui avait un cancer du sein. Elle avait 45 ans, sa mère, quand elle avait le cancer du sein. Donc, avec une histoire familiale, comme Ampik vient de le dire, ici se posent toujours les questions. Est-ce qu'il faut faire le BRAC 1, BRAC 2? Donc, je crois qu'il faut faire pour tous nos malades des BRAC 1, BRAC 2, comme l'olaparib est un bon traitement, comme on vient de le voir. Je vais le reprendre ça. Donc, c'est une femme, on a fait une évaluation. C'est un cancer du sein qui était de 2,1 cm. Elle n'avait pas d'autres lésions autre part. Le PET scan était négatif, bon état général de la malade. Et donc, à l'anapathe, donc c'était un cancer du sein invasif, c'est un adénocarcinome qui était de grade 3 et qui était triple négatif. Donc, la première question, je vais répondre aux questions comme c'était déjà demandé. Est-ce qu'il faut faire le BRAC? Donc, tout triple négatif, je crois maintenant, chaque cancer du sein avec le BRAC 1 est un must. Pourquoi c'est un must? Car on a des traitements qui sont spécifiques en adjuvant pour ces malades. Deuxièmement, est-ce que le PDL1 est un must MU? C'est pas grave. Donc, oui, c'est un must et non, ce n'est pas un must. Et c'est important pour les non-oncologues. Le PDL1 en adjuvant, donc quand on traite les malades en adjuvant, ce n'est pas une nécessité. Pourquoi? Car tous les malades en adjuvant, tous les malades qui sont triple négatifs peuvent être traités en néoadjuvant et adjuvant par de l'immunothérapie, quel que soit le PDL1. Donc, le must est dans les traitements, dans les cancers du sein triple négatif métastatiques. Troisièmement, quelles sont les propositions de traitement chez ces malades? Donc, on peut faire une chimiothérapie au début, puis ajouter olaparib ou, comme on a bien discuté maintenant, commencer par un néoadjuvant, par une chimio-immunothérapie et puis continuer par une immunothérapie en adjuvant. Donc, cette malade était discutée au MDT. Donc, la discussion dans le MDT, c'est un triple négatif de donner une chimiothérapie néoadjuvante par une chimio-immunothérapie et puis suivie par une immunothérapie en adjuvant. Donc, cette malade a débuté son traitement avec de la chimio-immunothérapie. Ce qu'il faut savoir que l'immunothérapie peut faire des complications. Et ça, c'est important à savoir pour les non-oncologues. Déjà, dans l'étude, on avait 2 malades dans la chimio néo-adjuvante et adjuvante qui sont morts de l'immunothérapie. Donc, il faut faire attention que c'est en adjuvant. Et mourir en adjuvant, c'est un peu compliqué. Et donc, faire attention à ça. On peut avoir des complications avec l'immunothérapie. Cette malade a fait des complications de diarrhée qui étaient graves où le traitement était arrêté pour quelques semaines. On a traité la diarrhée et puis ça a marché. Et puis, dans l'adjuvant, elle a refait un problème d'hypothyroïdie qui était traité pour son hypothyroïdie. Donc, ce qui est important pour les non-oncologues, que oui, l'immunothérapie est un très bon traitement et cette immunothérapie peut faire des complications. Et je reprends que l'immunothérapie actuellement dans les cancers du sein est utilisée uniquement dans les triples négatifs. Il n'y a pas de place de l'immunothérapie dans les cancers du sein qui sont soit HER2-positifs, soit hormonopositifs. Donc, il n'y a pas de place actuelle pour l'immunothérapie dans les autres sous-catégories de cancer du sein. Donc, je reprends, l'immunothérapie est uniquement utilisée dans les cancers du sein triple négatifs, quel que soit le PDL1 en néoadjuvant et adjuvant, donc dans les cancers du sein précoces. Et quand on a des métastases, il faut faire le PDL1, il faut avoir un PDL1 positif, un CPS plus que 10, donc pour utiliser l'immunothérapie. Donc, c'est des petits détails qui sont importants pour les non-oncologues, comme la plupart de nos collègues ne sont pas des oncologues. Donc, quand j'ai un BRAC positif, quel est le meilleur traitement? Ici, il n'y a pas de meilleur traitement. Et ça, c'est les grandes questions qu'on se pose. Quand on a un BRAC positif, on a 2 choix thérapeutiques. L'olaparib est un traitement en adjuvant qui peut être discuté et l'immunothérapie est un traitement qui peut être discuté. Comme je vais vous faire voir la dernière slide, dans les grands centres, on peut traiter les 2. Pourquoi la deuxième question pour le Xeloda? Donc, vous savez, avant l'ère des BRAC et de l'immunothérapie, on utilisait chez les triples négatifs, chez les malades qui avaient une maladie résiduelle dans le triple négatif, 1 an de chimiothérapie par capecitabine, par Xeloda. Et donc, c'est un traitement qu'on peut discuter chez ces malades. Au Liban, de plus en plus, on revient à ça, car actuellement, on a un grand problème d'argent, comme vous savez. Et donc, malheureusement, on a beaucoup de malades qui ne peuvent ni se permettre le Laparib qui coûte à peu près 4 000 € par mois, ni se permettre l'immunothérapie qui coûte 5 000 $ chaque 3 semaines. Et donc, on a beaucoup de malades qui ne peuvent pas se le permettre actuellement. On revient à ces traitements anciens qui sont comme le Xeloda. Et donc, vous allez voir dans les grands centres, on donne du Xeloda, par exemple, avec de l'immunothérapie. Et donc, ça, c'est leur standard chez ces malades. Donc, cette malade, comme vous voyez ici, elle a fait sa chirurgie, elle a fait une rémission pathologique complète. Et puis, elle a eu l'immunothérapie pour 9 cycles en post-chirurgie avec, comme j'ai dit, des complications d'hypothyroïdie, donc fatigue, ainsi de suite. Il faut savoir qu'on fait des bilans systématiques en immunothérapie, comme l'examen de la thyroïde chaque mois, car c'est la complication la plus fréquente qu'on voit en immunothérapie avec des hypothyroïdies qu'on traite avec un traitement symptomatique et cette hypothyroïdie peut rester à vie. Et donc, c'est une complication qui est fréquente et qui peut persister. Donc, ça, on revient en arrière. Je fais un update rapide qui était déjà présenté par notre ami Dr Ampig. Donc, ça, c'est le néoadjuvant qui a présenté Ampig. Donc, c'est un traitement actuel qui a mis l'immunothérapie en néoadjuvant puis en adjuvant. Je ne vais pas reprendre. Ce qui est très important à savoir, c'est qu'on a augmenté les réponses pathologiques, quel que soit le PD-L1, comme vous voyez ici. Donc, quand je traite une malade avec un triple négatif, j'ai à peu près 65% de ces malades qui vont faire une rémission complète. Donc, je reprends 65% de ces malades vont faire une rémission complète, ce qui va affecter une excellente survie et un excellent event-free survival pour ces malades. La deuxième chose importante, comme vous voyez ici, on avait l'event-free survival qui était positif avec l'immunothérapie contre les non-immunothérapies d'une façon très importante, ce qui a mis le standard chez ces malades et on a eu l'FDA approval. La deuxième chose qui est importante, même si cette malade qui n'a pas pris de l'immunothérapie, elle a fait une rémission complète. Regardez les deux courbes en haut, donc ils sont excellents. Donc la différence se voit surtout chez les malades qui n'ont pas fait une rémission complète, donc en bas, comme vous voyez, donc qui n'ont pas fait des pathologic response. Donc ici, la différence est hyper importante, alors qu'avec les malades qui ont fait une pathologic complete response, même si elle n'a pas pris de l'immunothérapie, elle a d'excellents résultats pour dire que les malades qui répondent très bien au traitement, c'est des malades ils ont pris ou n'ont pas pris de l'immunothérapie, vont répondre très bien. Et ça, c'est la survie. Actuellement, ce n'est pas significatif, mais comme vous voyez que les courbes commencent à se différencier et on croit qu'avec le temps, on va avoir une différence de survie. À partir du juin 2021, donc l'immunothérapie est un standard chez les triples négatifs, quel que soit le PD-L1. Un mot sur l'adjuvant. Donc, dans l'adjuvant de ces triples négatifs, comme j'ai dit, le Xeloda, suite à cette étude, est un standard, peut être un standard chez ces malades, surtout quand on a une maladie résiduelle. Et comme vous voyez les courbes en bas, on a une grande différence en disease-free survival et en survie chez ces malades, donc déjà publié en 2017 dans le New England Journal. Et ça peut être, comme j'ai dit, une option thérapeutique quand on a des problèmes, que ce soit avec les PARP inhibitors ou que ce soit avec l'immunothérapie, comme c'est actuellement dans notre pays, malheureusement, à cause des problèmes financiers. Ça, c'était présenté aussi, ça c'est l'Olympia, dans les triples négatifs, les PARP inhibitors, quand c'est BRAC positif, a mis sa place et c'est un standard avec ITT, Invasive Disease Free Survival, chez tous les malades avec une grande différence, donc un très bon hazard ratio et avec une survie qui est positive. Quelles sont les grandes questions qui restent? Quelle est la place de l'adjuvant de l'immunothérapie? Est-ce que pour tous nos malades, c'est nécessaire, comme j'ai dit, si je fais une rémission complète, après le néoadjuvant, est-ce que l'immunothérapie est un must? Donc, cette étude va répondre à cette question. Est-ce que je dois donner l'immunothérapie quand je fais une rémission complète? Donc, cette étude qui va étudier ces malades avec Pembro ou sans Pembro, on n'a pas encore les résultats, c'est le SWOG 14-18. Et donc, pour voir l'immunothérapie en adjuvant, quelle est sa place, donc c'est important. Et ça, c'est la même étude en essayant un autre type d'immunothérapie qui est la tezolizumab. En fin de compte, ça, ce n'est pas ma slide, c'est le slide de notre collègue au MD Anderson. Et donc, comme vous voyez, la deuxième partie, donc à votre droite, les malades, qu'est-ce qu'ils sont en train de faire au MD Anderson? Donc ça, je l'ai pris de notre docteur au MD Anderson. Donc, quand j'ai un cancer du sein triple négatif et j'ai un BRCA qui est wild type, qui est normal, il utilise l'immunothérapie en adjuvant, mais il utilise aussi le Xelode, comme j'ai dit, en adjuvant. Donc, il utilise les deux. Est-ce qu'on a une preuve sur ça? La réponse est non. Mais dans leur standard, ils utilisent ces doubles thérapies en disant que c'est des malades qui sont très graves et on peut faire un mieux tout en sachant qu'on n'a pas de preuves. Comme je dis, il y a beaucoup de questions et des études sont en train de se faire. Et aussi, au MD Anderson, leurs habitudes, c'est quand on a un BRCA qui est muté, est un triple négatif, ils utilisent l'appareil comme un traitement, mais ils ajoutent aussi, après l'appareil, l'immunothérapie, plus ou moins immunothérapie, pour dire que dans les grands centres, ils ont leurs habitudes de faire ça, même si ce n'est pas un standard, et ils sont en train d'attendre, comme j'ai dit, l'étude du SWOG pour voir quelle est la place de l'immunothérapie en adjuvant, surtout quand on fait une rémission complète après le néoadjuvant. Voilà, merci. Questions? Donc, on entend.
Oestrogène récepteur positif. لا انا استرتي
ايه ما هي
مش هيدا استرتي احي ثانك يو خلص كونتينيو يضل هذا بوجهي يفتح تيمز شو عم يصير
خلاص مش
بدك تسويها هيك كيف بحرك انا شو بحرك عملت هيك بحرك بنزلهم هون بدك خلص
خليني نسكر اللي قبله بس لأنه فاتحين كذا بريزنتاسيون فمعلق
نادين رح تقول له نادين رح تقول له لكن هونيك اتس فول سايز معلش
ايه بس لا حتى تقدر تغيره
مين بيعرف يظبطه
هيك
هيك خلاص اوكي ميرسي بوكو دكتور نصر دكتور عطلة. So I wanted my talk to be beneficial to everyone. So it's going to be about metastatic hormone receptor positive breast cancer and the adjuvant treatment of HR positive breast cancer. So I tried to summarize everything we know about hormone receptor positive breast cancer in the 15 minutes that we're going to see based on the clinical case that we have.
So we have the case of it's very common presentation, 49-year-old female who had a right mastectomy for a 3.4 centimeter invasive ductal carcinoma, estrogen receptor positive, HER2 negative, high grade, Ki67 30%, and 4 positive lymph nodes. So this is stuff that we see every single day. So this is a stage 3 cancer patient. She received adjuvant chemotherapy, as she should, with 4 cycles of AC and then Taxol. And then she, to go back to her menopausal history, she was having irregular periods with her last cycle occurring 3 months prior to surgery. So this is very important also for our fellows. Her blood work now reveals FSH, LH in the menopausal range. So the question is, and it's very, it's going to be very detailed, which of the following endocrine therapies would you recommend? Tamoxifen, we're going to elaborate on each one of these. Aromatase inhibitors for 5 years, for 10 years, aromatase inhibitor and ovarian function suppression with GnRH agonist, abemaciclib plus tamoxifen. There's a delay. There's a lag. Huh? هونيك في lag. Okay. بعد فيه ناقص. شو عم بصير؟ abemaciclib plus AI plus GnRH agonist. مين حطها بالجونة؟ هن ذربوري؟ طيب ما بعرف شو عم بصير. اوكي ليش ما خلوا حد ما بدهم السلايدز تبعي؟ ما بعرف. I don't know what's happening. Anyway. All right, guys. So the answer is, I see. So they're switching between presentations. طيب. So the question, the answer is F, and we're gonna see why. Now, before we do that, I'm going to the second question. When the patient became metastatic. So the patient did not receive this. She received tamoxifen after her chemotherapy. She was premenopausal. So a year later, she presented with new back pain. She was found to have metastatic disease, bone lesion, pulmonary nodules, liver lesions. LFT is normal. She had a biopsy of a liver lesion showing recurrent ER-positive breast cancer, MSI high. So she was started on zoledronic acid. What would you give her next? Chemotherapy? AI plus ovarian suppression with a CDK inhibitor, everolimus with exemestane, or immune therapy? All right, so let's go back to the first question and elaborate a little bit on this. So there's a lot of intricacies here. Do we give a 49-year-old tamoxifen or AI? So AIs are ineffective in premenopausal patients. The definition of menopause is very clear, and we have to abide strictly to the NCCN guidelines. If a patient had prior bilateral oophorectomy or age greater than 60, that's the definition of menopause. If the patient is less than 60 and has been amenorrheic for 12 months or more in the absence of chemotherapy or hormonal therapy, because a lot of these patients come to us at the age of 52, and the period stops when we start treatment because of the stress, because of the chemotherapy, but the ovaries are still functional. And these patients do not benefit from aromatase inhibitor. They are considered to be pre-menopausal. If we start an AI, we have to do serial FSH and plasma estradiol level to make sure that the patient remains in menopause. So we have strong data to show us that in postmenopausal women, actually an AI is more beneficial than tamoxifen, and you can see here on the curves the recurrence rate, which is higher in patients who receive tamoxifen in the postmenopausal status. So the second point that came up in the question is ovarian function suppression for a premenopausal woman. Should we do it or not, and when is it indicated? And we have 2 trials that answer that: the SOFT and the TEXT trials, which randomized premenopausal women to receive either tamoxifen alone, tamoxifen with ovarian suppression, or aromatase inhibitor with ovarian suppression. And the results were very clear. When you look at patients who were assigned to receive by the oncologist to receive chemotherapy, these were considered to be patients at high risk. Those patients actually benefited, this is on the right, they benefited from the addition of ovarian suppression. while the patients who were not assigned to receive chemotherapy, low-risk patients, actually did not benefit from the addition of ovarian function suppression. The problem with ovarian function suppression is obviously the side effects. You're looking at all the postmenopausal side effects. I will not go into a lot of detail here. So when do we do ovarian suppression? It's appropriate for high-risk cancer patients, stages 2 or 3. It has substantial more toxicity, and it has to be clear that giving an AI for a premenopausal patient is not effective. Now, what about the duration of endocrine therapy? It came up also in the questions. Do we give 5 years or 10 years? This is also a very important question. We know that these patients with estrogen receptor positive breast cancer, HER2 negative, these are patients that can have very late relapses. They behave differently than other kinds of breast cancers. You can have relapses up to more than 10 years after the diagnosis and the treatment, especially with patients with lymph node positive disease. You can see over here the risk of relapse that rises drastically. And this is, we're talking about 10 years here after treatment. So there's an interest in giving these patients prolonged endocrine therapy. The Atlas trial answered that by comparing 5 versus 10 years of tamoxifen and showing a significant difference in breast cancer mortality. What is very interesting, by compiling all the data, it's very interesting to see that the patients who actually benefited from prolonged endocrine therapy were the patients who received initially tamoxifen. So if you get tamoxifen and then tamoxifen for 10 years, so 5 years and 5 years, or if you receive 5 years of tamoxifen followed by 5 years of aromatase inhibitor, these are the patients who benefit the most from extended endocrine therapy, more than the patients who just receive AI for 10 years. Also, the patients, obviously, who have lymph node positive disease are the one who benefit the most from prolonged extended endocrine therapy. So we limit this to patients with stage 2 and stage 3, some patients with stage 1 on an individual basis, especially patients who have tolerated treatment and patients who have started with tamoxifen, and probably, because we don't have more data at this point, no longer than 10 years because of the cumulative side effects. Now, why was F the answer for this patient? This is a patient with stage 3 positive lymph nodes, high-grade disease, 3.4 centimeter mass. Why are we giving her abemaciclib, which is a CDK inhibitor, in the adjuvant setting? The Monarch E trial answered this by studying 5,600 patients and randomizing these patients to either endocrine therapy alone or abemaciclib plus endocrine therapy. And the study showed in these patients a significant improvement in invasive disease-free survival and distant relapse-free survival in patients who received the adjuvant CDK inhibitor. These are the subgroup, and I'm not going to show everything here, but this is the cheat sheet, basically. These are the patients who are candidates for adjuvant abemaciclib. When you have 4 or more positive lymph nodes, when you have a T3 lesion with N1 positive lymph nodes, when you have a T2 with N1 to N3 if the grade 3 or above. So the grade is very important here. These are aggressive patients, aggressive cancer, and they warrant receiving adjuvant CDK in addition to the endocrine therapy. So now we're going to move to the metastatic setting. So this patient developed metastatic disease. She has liver mets, she has lung mets, she has bone mets. So what do you give this patient? Did anyone think about giving chemotherapy? So chemotherapy in these patients has become actually mismanagement at this point. There's a very clear stance of ESMO, ASCO, and everyone else that chemotherapy in this setting is actually the wrong treatment. We have very strong data and studies to show that giving chemotherapies to these patients actually results in poorer overall survival. The curves are very clear. They have worse quality of life with chemotherapy, and they have greater toxicity with chemotherapy. We have a multitude of trials that show that giving endocrine therapy with targeted therapy, CDK inhibitors, is the standard of care. The only exception is patients who present with a visceral crisis where we need very quick and urgent response. So these are patients who have lymphangitic spread in the lungs and shortness of breath, desaturation. These are patients who have hepatic failure, elevated bilirubin. These are not patients who are asymptomatic and just have a couple of liver mets and a couple of lung nodules or many lung nodules. As long as the patient is asymptomatic, they can start with targeted therapy, and it is the standard of care. So there's a multitude of trials because we have 3 CDK inhibitors. We have ribociclib, palbociclib, and abemaciclib. And the names of the trials will actually follow the drugs depending on the pharma company. So everything related to palbociclib will be Paloma, ribociclib, Mona Lisa, and then abemaciclib with the Monarch trials. So these are patients who have metastatic disease. And across the trials, you have pretty much the same numbers in terms of median progression-free survival, 25 versus 15 months if you're using a combination of a CDK inhibitor plus endocrine therapy versus endocrine therapy alone. Also improvement in overall survival. It's difficult to compare, impossible to compare trial to trial in terms of numbers for overall survival because of patient selection, but we pretty much think that all of them are equivalent in terms of efficacy. I'm going to show some quick curves without commenting too much, just to show you how the curves are very similar. So in the Paloma 2, performance-free survival, Mona Lisa 2, Monarch 3, everything is basically pretty much the same. Mona Lisa 7 is interesting because it studied premenopausal women who were on tamoxifen. So it actually randomized patients to receive ribociclib with tamoxifen or an aromatase inhibitor versus endocrine therapy alone. And this also showed an improvement in performance-free survival and overall survival. But what is more interesting is that patients who received, oh, I cannot go back. Let's see. Here we go. So patients who received an AI actually did better than patients who were on tamoxifen. So the standard of care would be to do, if possible, an AI with the CDK inhibitor plus ovarian function suppression in these premenopausal women who have metastatic disease. In terms of second line, same kind of data, same kind of studies, progression after endocrine therapy. So a patient who's already receiving endocrine therapy and then present with metastatic disease, same thing. We often use fulvestrant. You can also use an AI. So we have the Paloma 3, Monarch 2, and Mona Lisa 3 showing all significant improvement in PFS and also in overall survival. This is Paloma 3, Monarch 2, overall survival for Monarch 2, and then Mona Lisa 3 in PFS and also with overall survival. In terms of the differences between the CDK inhibitors, there's a dosing schedule difference, and there's a little bit of difference in side effects. They can all cause neutropenias and pancytopenias, so we have to watch them. We're pretty used to doing this. There's a little bit of difference in terms of diarrhea and QT prolongation for a couple of these drugs. And that's everything I have. Any questions?
Hi, can you hear me? Can you hear me? Can you see my screen? Can you see my screen? Can you hear me? Okay. Can you hear me or not? Can you hear me? Can you hear me?
ما عم بيطلع الصوت ولا عم تطلع
Can you hear me?
presentation تبعه وين؟
هو بيعمل شيء.
اوكي يعني احنا
لا بس
اوكي بدنا نعمل له شيء.
Can you hear me now?
تلقينا عملت شير
هنا دين.
سكرين ساوند.
لا.
علي شوي ساوند.
الو عم يسمعوني؟
Yes, now.
هلا عم تسمعوني؟ اوكي. Can you see my screen or not?
بس بدنا نشير السكرين عادي حتى تبين.
هلا بينت سكرين هلا.
Yes, full screen, please.
Full screen.
Yes.
Yes.
Now we're good.
Yes.
اوكي هبلش
هلا هون خد duplicate. تعرف.
I would like first to thank the organizer, David, and the oncology department for inviting me today to talk about the state of the management of loco-regionally advanced HER2-positive breast cancer. I'm in ESMO now in Madrid, and so I took the opportunity to give you this lecture from here. You can see the slides and you can hear me, right? Okay. So basically, we're going to present a very complex patient. You're going to see a complex patient. Most of the talk will be about this complex patient, and then we will present the state-of-the-art management of HER2-positive, loco-regionally advanced breast cancer. So this will not be a metastatic case. It will be a very advanced stage 3 case. So it will require a team, an expertise and precision to give this woman the optimal chances at cure. And I will walk you through this in the next 15 minutes, how to put a team together and special expertise and precision to deliver the right outcomes. So she initially presented to me a few months ago on 4th of July 2023. Her history of present illness, she's 54-year-old female. She felt some skin masses in her left breast. She is saying she felt them 4 months before presentation. Her last mammogram was back in 2018. On review of systems, she didn't have any weight loss, any headache, or any body aches. Her past medical history was not significant. She has some hypercholesterolemia and she had cholecystectomy a couple of years ago. She does smoke 1 pack a day and she is postmenopausal. Her period stopped in 2018. She is 54. She didn't have any family history of breast or ovarian cancer. Her maternal aunt did die of uterine cancer. And she was only on Crestor. So basically on physical exam in the right breast, there was some skin lesions in the right breast, 3 by 3 centimeter and 3 by 2 centimeter. And in the left breast, there was a fungating mass around 20 by 20 flat mass in the left breast. It was an inflammatory breast cancer with complete skin involvement. And there was pus coming out and a defect in the nipple area. There was a 1 centimeter lymph node felt in the ipsilateral left axilla, and she had a large 4 by 4 centimeter matted left supraclavicular lymphadenopathy. And also, as part of this supraclavicular, she had some lymphadenopathy in the left lower neck. In the left lower lateral neck, she had some lymphadenopathy as a continuation of the left supraclavicular lymphadenopathy. This was the picture of the patient when she presented to me on the 4th of July. So you can see an inflammatory breast cancer, there was pus coming out, there was crusting. So this is a very advanced, at least loco-regionally advanced breast cancer. And so when she came, we didn't have any biopsies yet. And so she had an inflammatory left breast cancer, I was sure about that. And she had right breast skin involvement. So basically what I ordered as the initial diagnostic test on this patient, I ordered core biopsy of the left breast at Hôtel-Dieu de France. We ordered an ultrasound and mammogram. They couldn't do the left mammogram, so they did the right mammogram. We ordered systemic staging with PET scan and labs with tumor markers. The labs didn't show any significant abnormality. The tumor markers were actually normal, which was kind of a relief because I expected it to be higher than that. And on the right mammogram, she had actually in the right breast, which was the other breast, she had intraparenchymal masses. So she also had something that was suspicious in the right breast, especially in the lower quadrants and in the right breast skin. And she had enlarged pathologic right axilla nodes. Now, on the ultrasound in the left breast, she had the left large malignancy with skin ulceration and enlarged pathologic left axilla and left supraclavicular nodes. On the PET scan, we did the PET scan. So she had the large inflammatory left breast cancer with left axilla, lymphadenopathy. She had left lateral lower neck and left supraclavicular lymphadenopathy. She also had a smaller right breast cancer, right axilla LAD. So she did have also a right breast cancer. She didn't have any metastatic disease. She only had some degenerative bone changes at L4, L5 that we will follow, but she didn't have any distant metastatic disease. So this was the PET scan. You can see the inflammatory left breast cancer. You can see some activity on the right breast also and the right axilla. And you can see here the left supraclav and left neck lymphadenopathy. This is the PET scan. You can see the large mass in the left breast. And here you can see also the mass and activity in the right breast. So basically, we did at Hôtel-Dieu, we did bilateral core biopsies of both of her breasts. Both showed invasive ductal carcinoma. It was a grade 2. And both on the receptor had the same receptor profile. It was estrogen and progesterone negative, so hormone receptor negative, and HER2 positive disease, and the Ki67 was 35%. So it's important to note here that you have the same receptor profile and the same grade and the same histology on both sides. So I took the phone, I called Abir Khaddaj, and I told her, what do you think? Is it the same tumor? She said it's exactly the same histologically by grade and by receptor. So we both think that it's coming from the same tumor. So this is a tumor that started in the left breast and then metastasized to the other right breast. It's not a different primary. This is important for the management. So basically now you can see that she has a left breast cancer that's metastasized to the right breast. It's a T4 inflammatory breast cancer. She has an N3 disease on the left with supraclavicular left matted lymph nodes. And she can be considered also M1 since she had the right breast is involved. She can be considered M1. And the left lateral neck, also this puts her at an M1. However, the PET scan didn't have distant visceral mets per se. And like we said, both have the same receptor profile. So the first question that we'll ask you here, what would you do next in the management of this patient? Would you recommend upfront surgery? Would you recommend endocrine therapy? Would you recommend multidisciplinary consultation, i.e. radiation therapy and surgery initial consultation? Or would you send her to hospice for best supportive care? And the answer to that is I would recommend multidisciplinary consultation. I cannot stress enough the importance of initial multidisciplinary consultation, evaluation, and discussion as part of an official tumor board. And this is very important for best outcomes in these kinds of patients, especially in the complex patients like that. The second question, so what is the next step in the management of this patient after having done the multidisciplinary discussion? You would send this patient to the surgeon for upfront surgery. You would offer palliative intent chemotherapy with docetaxel, Herceptin, and Perjeta. You would offer this patient curative intent neoadjuvant chemotherapy, or you would send this patient for palliative radiation therapy. Actually, it's a complex case, and we did think in the tumor board that she would benefit from curative intent neoadjuvant chemotherapy since she didn't have distant metastatic disease in visceral organs like the bones or like the liver or the lungs. So basically, she could be offered theoretically later on curative intent surgery on both sides. So this is why we decided to go with curative intent neoadjuvant chemotherapy. This is the state of the art. You know, this is the Trifina trial that was one of the clinical trials that led to the neoadjuvant approval of Perjeta. You can see here you have a 63% pathologic complete response in the breast if you use the regimen Taxotere, carboplatin, Herceptin, and Perjeta ×6. So a 63% rate of pathologic complete response in the breast and the lymph nodes can be achieved by using this regimen. So basically, this brings us to the next question. Since we decided we're going to give her neoadjuvant curative intent chemotherapy, what would you use as this preoperative systemic therapy? Would you use single agent Herceptin? Would you use a CDK4/6 inhibitor and letrozole like Jad has shown us in his lecture? Would you use weekly paclitaxel chemotherapy, or would you use TCHP times 6 every 6 weeks, meaning docetaxel, carboplatin, trastuzumab, and pertuzumab? The correct answer is to use, like I've shown you in the pathologic complete response, is to use TCHP times 6 every 3 weeks. This is a curative intent neoadjuvant chemotherapy. So this is what I recommended. I recommended neoadjuvant chemotherapy with TCHP times every 3 weeks times 6, then surgery, then HP times 12 versus Kadcyla, depending on residual disease, with, of course, adjuvant RT. She is ERPR negative, so she will not benefit from endocrine therapy in the future. So this is the regimen that we use: Taxotere at 75 milligram per meter square, carboplatin at an AUC of 6, Herceptin and Perjeta. It's very important in cases like this to use the full chemotherapy dose to give those patients the maximum chance of cure. So basically, what will she need after chemotherapy? So after preoperative chemo, if she responds well, she will need bilateral mastectomy, bilateral axilla dissection, since she had node positive on both sides, right axilla, right side also, and the skin on both sides needs to go. And we will look. I will show you the pictures now. And in terms of radiation therapy, she will need comprehensive radiation therapy to the left breast, left axilla, left supraclav, and also the left lateral neck. And depending on the response in the right axilla, we might also add adjuvant radiation therapy to the right axilla also. So basically, this is what I do in my clinic. Whenever you give neoadjuvant therapy, you can't analyze and improve what you don't measure. So every time I see them in the clinic, every 3 weeks during chemotherapy, I have to measure the primary mass. In this case, I measure the cancer in the left breast, and I see if she's responding well. This is not like in the adjuvant setting where you have done the surgery and you give blindly the chemotherapy. Here you have a chance to measure in vivo the response of the chemotherapy, and this is why it's so important sometimes to give the chemotherapy in the preoperative setting. So this patient did respond well, and I will show you this in pictures. So this was on the 4th of July. You can see the eaten out fungating mass. This was the right breast. You can see the metastatic skin lesions in the right breast, the contralateral right breast. This is still initially before chemotherapy. This is the right breast. So this is also before chemotherapy, the left breast. And after 3 cycles of chemotherapy, I'll show you what we have. So this was before, and this is after 3 cycles. You can see that the skin is reepithelializing. You have a shrinkage of the mass. You can start to recognize again the nipple areola in her left breast. So this is on the 26th of September after 3 cycles of chemotherapy. This 26th of September. And after 4 cycles of chemotherapy 3 days ago, this was 3 days ago, after 4 cycles of neoadjuvant chemotherapy, you can see clearly again now, we can recognize the areola and nipple, and we have a reepithelialization. So this patient is responding very well to neoadjuvant chemotherapy. This was before, and this is now. So she's responding very well. And so basically, we will talk now quickly about state-of-the-art treatment of early stage 1, 2, and 3 HER2 positive breast cancer. So this patient is still considered curable. So it's part of the stage 3. So on September 30, 2013, back in 2013, the FDA granted accelerated approval for Perjeta and Herceptin combination with docetaxel for patients like this that had curable breast cancer in the neoadjuvant setting, and pertuzumab was the first FDA-approved drug for the neoadjuvant treatment of breast cancer. So at the time, there was no other drug that was approved, specifically to be used in the neoadjuvant setting. And after that, it got approved for also the adjuvant setting. The approval was based on the NeoSphere trial, which was a phase 2 trial, that showed high efficacy, significant efficacy in the neoadjuvant setting in the treatment of locally advanced inflammatory or early HER2-positive breast cancer. So the outcomes here were in the intent to treat population, as you can see, there was a 46% pathologic complete response rate when you use docetaxel, pertuzumab, and Herceptin versus trastuzumab at the time, which was the standard of care. Trastuzumab and docetaxel, only 29% complete pathologic response. Here there was 46%. And this is even without carboplatin. So carboplatin adds to that efficacy. It improves, like we showed, up to 63% the pathologic complete response rate. So based on these results, pertuzumab became part of the neoadjuvant therapy, preoperative therapy for patients like the one I showed you. This is the Trifina trial. This is the Trifina trial that was initially designed as a cardiac safety study to see if Herceptin and Perjeta used together could improve the efficacy while staying safe in terms of cardiac side effects. This is the slide I showed you. You can see here the pathologic complete response rate in the lymph nodes and in the breast was 63% and was the highest of all the other regimen when used 6 times in the neoadjuvant setting. That's why it's the preferred regimen. In terms of 4-year survival by breast cancer subtype, you can see that the most curable breast cancer subtype is the hormone receptor positive, HER2 negative breast cancer with a 92% 4-year survival. This is followed by HER2 positive, hormone receptor positive, 90% survival. Our patient fits in the third category, the 83% 4-year survival, where she has hormone receptor negative. She is ER negative and HER2 positive. And the one where we have the most the most negative survival is triple negative breast cancer at only 77% 4-year survival for early stage breast cancer. So basically, this is the NCCN that shows us the standard of care. The standard of care for this kind of patient in early stage is Taxotere, carboplatin, Herceptin, and pertuzumab for 6 cycles. These are some other regimens that are also approved, like AC or dose-dense AC, followed by Taxol, trastuzumab, and pertuzumab. This is another regimen that can be used with high efficacy. So thank you. Thank you very much for the opportunity to discuss this case. Any questions?
Out of time. Thank you. So we move to our team pathology.
I cannot hear well.
Hello, Mr. Wendy. Our pathologist.
If there is a question, can you repeat the question or? Okay. I couldn't hear the question. Okay. Okay, thank you. Bye.
هلا المفروض Allô? Vous m'entendez? لا مشيته مش من هون. هلا ماشي.
Yes, can you hear me? Okay, so I'll be taking you out of the oncology world a bit and diving you into the pathology world. My slides are in French, but I will be talking in English. الميكرو منه ماشي. جايين اوكي. الميكرو ne marche pas. قال لي انه جايين في حدا نزل عني.
Tous les micros ne fonctionnent pas, je pense.
Déjà super.
بس جاي
This is now منه ماشي. بس عم بيسمعوا هلا. Okay, we're good. Can you hear me? Yes. Okay, so my slides are in French. I'll be talking in English. I present a case of a young woman, 33-year-old, presenting for an autopalpated left breast mass. She has done an ecography showing a hyperechogenous area measuring 4 centimeters, classified SER3, and then on the control ecography, we still had this hyperechogenous area, and then we had some hypoechogenous apparition of a new lesion measuring 2.7 centimeters, classified ACR4. She did a mammography showing this opacity, and she was programmed for a microbiopsy. So on the biopsy, we had biopsy of the 2 sites, and the 2 sites showed the same image on the microscope. So I'll be showing you what we saw on the microscope. I will not be commenting now, so you can answer the question later on. So this is a magnification 4. You are seeing the fine needle biopsy. This is magnification 10. And this is the magnification 20. يا محلى الأنكور. Alors, what's your diagnosis? Normal parenchyma, benign lesion, infiltrating carcinoma, sarcoma, and I need to do some special techniques. Okay, so vote please. Okay. The vote is done. Yes. Okay, so 42% have a wrong answer. The correct answer for now is I need to do some more techniques. So let's see what about these techniques. We did some immunohistochemistry. We did the antibody anti-cytokeratin. You see here on your left, and it is highlighting the epithelial structures that are surrounded by a myoepithelial layer with a P63. So this is not an infiltrating tumor, okay? And in between these epithelial structures, what we were seeing in between the epithelial structures, these cells are not cytokeratin positive. So now, this is not normal parenchyma. This is not an infiltrating carcinoma. Can you go ahead with your answer? Benign lesion, sarcoma, need to do more techniques? More techniques. Great. So now let me comment on this slide. So we're seeing a proliferating tumor with a double component. Okay, so we're seeing a proliferating tumor with a double component. This is the first component of the tumor. It's the blue things you're seeing. This is the epithelial part of this tumor. And then the pink areas you're seeing is the conjunctival component of this tumor. So this is a biphasic lesion, okay, with a pericanalicular architecture, so around these canalicles. And whenever we're speaking about the conjunctival epithelial lesion, first thing that comes out to our mind is a fibroadenoma, right? But the conjunctival component is a bit too cellular. This is, I don't have a, okay, so thank you. So what you're seeing in the pink component, the stromal component, this all are cells, okay? And this is a bit too cellular for a classic fibroadenoma. There were no atypias, no mitosis, but still this was a bit too cellular for a normal fibroadenoma. And then again, we had something else that was a bit intriguing for a fibroadenoma. What you are seeing here are adipocytes. So this is entrapment of adipocytes inside this tumor. And this, again, is not classic for a fibroadenoma. So we were now in between two diagnoses, a phylloid tumor, low grade, and a cellular fibroadenoma, since she's young, 33-year-old. And we suggested to take out the lesion in order to analyze it in total. So the patient went through some surgery. She has a quadrantectomy, and the harpoon was pointing out a not so well circumscribed lesion measuring 4 centimeters. And again, the slides. So what we are seeing here, okay, so this is some adipose breast parenchyma, and this is the lesion here. It looks like it's well circumscribed, but again, look at the adipocytes inside, okay? And in other areas of this lesion, you can see clearly that the lesion is not so well demarcated. It's going around the galactophoric arborescence, okay? It's circulating in the parenchyma, sorry? Okay, I'll try to stick to the microphone. Okay, so in some areas, it looks like the tumor is well circumscribed, but then in other areas, you see that it is going around the galactophoric arborescence. What we are seeing is a proliferation of the periductal stromal around these canals that are a bit dilated, okay? And the conjunctival component is sometimes hypocellular and in some other areas hypercellular. So you see all the blue dots here are cells that are fusiform cells. No atypia or slight atypia, moderate, light atypia, no mitosis, up to 3/10 high power field. On immunohistochemistry, again, the cytokeratin antibody highlighted the epithelial structures, but in the component, the conjunctival component was completely negative. So this is not an infiltrating carcinoma. The conjunctival component was positive for CD34. So now, what's your diagnosis? Fibroadenoma, cellular fibroadenoma, phylloid, low grade, intermediate, high grade, or periductal stromal tumor? If you can vote, please. Okay, you're done. Okay, so let's see the answers. Okay. So the correct answer is periductal stromal tumor. Now let me guide you very briefly around the biphasic lesion of the breast. These can be benign or malignant lesions, and the characteristic is the presence of double population, cells that are epithelial in nature and stromal in nature, And then we divide these biphasic lesions upon the composition of the stroma. So if it's either a specialized intralobular stroma, and this is where fibroadenoma and phyllodes stand, okay, with the periductal stromal being a variant of the phyllodes. And if it's the non-specialized stroma, the interlobular one, this is where amartoma and PASH stand. So what about this rare entity? Around 50 cases reported in the literature. The mean age is postmenopausal women, 55-year-old. The clinical and radiological findings are not specific, okay, and the size varies between 2 millimeters and 6 centimeters. On the microscopy, we have nodules that are not confluent and that surround these dilated tubules. And the cells, you can see clearly here, that they infiltrate the adipocytes in between and the adipocytes of the parenchymal breasts. There's no phylloid aspect, so I'll be talking about this a bit later. Mitosis are variable, and very importantly, cytokeratin is negative. So is this a benign or malignant tumor? There was a famous study in 2003 by the famous Tavassoli, and they tried to put some criteria to distinct between benign or malignant lesion. And what they came out with is that now these are tumors considered to be biphasic, low-grade malignancy. The standard of care is surgery with sufficient margin, so the famous 1 centimeter margin. The adjuvant treatment, either chemotherapy or radiotherapy, are not recommended. With the latest WHO, the 5th edition, this tumor is considered as a subtype of a phylloid tumor. Okay, it was once considered as a distinct entity. Now it's inside the phylloid chapter. Why? Because we know that there's a lot of similarities with the phylloid tumor, so it can recur when the excision is not complete. It can develop a sarcoma. It has metastatic potential. It can develop intraepithelial neoplasia going from the usual ductal hyperplasia to the carcinoma in situ. These are lesions that are CD34 positive, as in phylloid. And very interestingly, the periductal stromal tumor can recur as a phylloid, so it can change its characteristic and recur as a phylloid. What are the differences between this and the phylloid? The limitations, so the phylloid, mainly low-grade and intermediate grade, are well-circumscribed lesions with some focal infiltrating areas, whereas the periductal stromal tumor is always infiltrating. It has no limitation. There's the famous phylloid aspect of the foliaceae. So look here, this is a phylloid tumor, and you kind of look like into a leaf. Okay, this is like a leaf pattern. This is what we call the phylloid or the foliaceae pattern. And mainly what happens is that the fusiform cells just push around. I don't have the cursor. They push the epithelial cells, and it creates a leaf-like aspect. This is what we see in the phylloid tumor and not in the periductal stromal tumor. And last difference is the age. So periductal stromal tumor is in elder women. Other differential diagnosis, so here very briefly, cellular fibroadenoma PASH, and these two last differential diagnoses are of concern. So you can mistake this for a carcinoma with fusicellular cells. The immunohistochemistry is really important. The cytokeratin will be positive here. And the soft tissue tumor, this is our main concern in pathology. Whenever these nodules are confluencing without epithelial structures in between, we can think of a soft tissue tumor, so melanoma, sarcoma, etc. And here again, the immunohistochemistry is really important. So let me stress out on this major idea I want to insist on, the limitation of the fine needle biopsy in these lesions. So this is our tumor, okay, with some well-circumscribed areas and other infiltrating areas. And if the biopsy, if the needle of the radiologist goes in here, what we're gonna see on the slides is just the component, the epithelial component and the conjunctival component. We're not gonna see the infiltrating characteristic of this lesion. So if the needle goes through here on histology, we're gonna say this is a biphasic tumor maybe a fibroadenoma. If the needle of the radiologist go through this aspect of the tumor, we're going to see clearly that this is an infiltrating tumor. So this is probably, most probably, not a fibroadenoma. So you see the limitation of the fine needle biopsy, and here clearly no log if the biopsy goes through just a component that is just stromal. So here we're going to think of a soft tissue sarcoma and not a biphasic tumor of the breast. So whenever we have any atypical criteria on the biopsy and whenever we have discordance between what we are seeing on the microscope and what the radiologist is saying, we recommend the excision of the tumor, and this is what happened in our case. So remember the fine needle slides I showed you? We were seeing just the stromal and the epithelial component. We were seeing just some small adipocytes at the periphery, and we weren't sure that this was a well-circumscribed or infiltrating lesion, and this is why we recommended the excision of the tumor, and eventually it turned out to be a periductal stromal tumor. Thank you.
Donc, last but not least, notre cher ami va présenter l'équipe. Donc, important, c'est l'équipe, rôle de l'équipe génétique dans une consultation et dans cette mission.
Thank you, Dr. Nasser. It's always difficult to be the last speaker in a long day like this, for me and for you. I'll try my best to interest you. Two words. I want to thank first Dr. Anas and the companion that came to us, visiting us. This is an encouragement for us. And for Dr. David, mes félicitations d'abord d'avoir maintenu tout le temps et l'effort que vous avez fait pour cette réunion. I'm going to talk about the important role of genetic counseling in breast cancer. I'm referring to 3 documents published by the UNESCO about bioethics. These 3 in 2003 and 1 in 2005, but what we are interested is in the International Declaration on Human Genetic Data and the genetic test, especially how to handle genetic tests and how to manage the human genome. The aim of this declaration is to ensure the respect of human dignity and the protection of human rights. This is the summary of what is there. And every time we have a collection, processing, or storage of human genetic data, this will be consistent with the human rights as it is in the Declaration of Human Rights. The 2 most important elements in this declaration is the consent. We can never take any initiative towards our patient without the consent of the patient. And you all know that if we have to obtain a consent from the patient, you should give a good information, very clear, very in the same language that the patient can understand. And so you might have the consent of your patient for the next step for the treatment. And we cannot now, in cancer, of breast cancer especially, go further in patients who have a genetic test or who have a genetic reason of their cancer without doing a counseling. What about the counseling? The counseling is when it is available, it should be done in a appropriate manner. First, it can be done by a genetician if the genetician is available. But I think that most of the time, people who are treating genetic diseases are trained and know how to counsel their patient and discuss with them about their diseases and the outcome of this disease. Two things should be respected all the time when we are dealing with genetic data, with genetic tests, is to respect the privacy and the confidentiality of our patient, because this depends on the individual in himself. Second, the family is involved. When we have genetic diseases, all the family should be involved in the process of taking care if they have not a same genetic disease. And of course, for research, we cannot involve a patient in a research study without his consent and without respecting his privacy and confidentiality. I'm going through a case scenario with you if you want to read it with me so that we can discuss some ethical issues that we are encountering in the genetic counseling or in the patient who have a genetic disease. We have Samar, who is 40 years old. Her mother, Salma, died of breast cancer at the age of 50. She recently came up some old family papers indicating that she has 2 maternal aunts and cousins in Australia. During her visit to them in Sydney, she discovered that one of her maternal aunts, Sahar, had been diagnosed with breast cancer at the age of 45, and that 2 of Sahar's daughters has also been diagnosed with breast cancer when they were in their mid-30s. Based on this family history, they had undergone genetic testing and a mutation of BRCA1 had been identified in Sahar and her daughters. When she returns home, she discusses this issue with her family doctor. He urged her to give a blood sample that he will send to a laboratory in order to screen for a mutation of BRCA1 and ask her to call back for the results in 1 month, as analysis of BRCA1, which is a large gene, is a lengthy process. It can take 1 month or more for this. So first question to the audience. What should the doctor have done differently, and where has he had, if he is wrong somewhere, where he was wrong in his management? You can answer directly. We don't have to do a on the board. This is the management of the doctor. He urged her to give a blood sample and sent to a laboratory in order to screen for a mutation and to call in 1 month to have the result. What do you think about the management of the doctor? He didn't do any counseling. 1, 2. Yeah. It was by telephone. Would you give these orders to your patient by telephone to tell her to do, or to call back and give her the result on the telephone? What about the consent? We know that in genetic, when you do a genetic counseling, you have obligatory to do a written consent and to sign by both the concerned people. So if we have the first issue, ethical issue, no genetic counseling was provided. Even if the doctor is not capable, is not trained to do a genetic counseling, he can refer his patient to a known person who is qualified to do a genetic counseling first. Second, he didn't explain anything to the patient. What are the risks of having a positive result or if it is a negative result? No consent was signed because no counseling, no consent. And consent is obligatory when you deal with genetic diseases. The third issue is no result or no discussion about genetic diseases should be done on the telephone. This must be done in a quiet area, face-to-face discussion and answer, and answering the question and the request of the patient, because they have so many questions to ask about the risk of having a genetic disease and what are the outcomes when we have a genetic disease. All this must be known before obtaining the consent of the patient. So the second scene, assuming all the right steps were taken previously, the results come back and Sahar is given an appointment to discuss them with the genetic counselor. The counselor explains that a mutation had been identified in her DNA and discusses with her what it means and what her options are. So I'm asking you, if you were the counseling, how can you, what do you explain to the patient about the result? What does that mean for the patient? Having a higher risk. What is the risk of having cancer? Well, 80% as an overall risk of cancer. And what are the options? When you explain to the patient, you should give them other options, because what are the options when we have a positive BRCA1, BRCA2 for a patient? Prophylactic mastectomy, 2, or observation and screening continuous, and 3, some are in the beginning they started giving a medication, anti-estrogenic treatment, but it doesn't work. It looks like it is not a good option. So all this should be given to the patient. Yeah, should be discussed with the patient if you want at the end a good informed consent and a decision from the patient. You should give them all the option and alternative. So here is what does the positive result mean. It means that a patient is at high risk for breast cancer and for ovarian cancer. We consider as for the breast cancer, it's almost, for the time life, it's almost about 85%. And for ovarian cancer, it's around 45%. So these are data that should be given in the counseling meeting to the patient for further decision about the treatment. And the options are here. We have monitoring by regular mammography, which is a screening starting at an earlier age, maybe at this is a lady with 45 anyway, but if she was a young one, we start at 25 years. Prophylactic mastectomy, but we have to explain about the body mutilation, take care about the psychological effect of this solution, and sometimes preventive drugs. This is an option, but this is not the best option, but we should talk about it with the patient. So the scene number 3. Sahar has 2 sisters and 2 brothers, but she is a very private person and did not tell any of her siblings about the test. She had done about the test that she had done and does not wish to tell them. However, she is concerned about her 3 daughters, Soraya, Sana, Soraya 9 years, Sana 15, and Serene 18, and wants to have their DNA tested. The question is, what are the dilemmas raised regarding other family members? What is the problem with this lady who doesn't want to share with her siblings, brother and sisters, about her result of genetic test? Is she, what do you think about that? What do you do? We try to advise her in many ways, even though she doesn't want to tell. But in the same time, we should make it easier for her to tell them. Because in our countries, there is some discrimination about having a genetic disease. People who are diagnosed with genetic disease doesn't like to diffuse the information because it's likely it is a discrimination for the family and for the person. So people try not to divulge their result of genetic disease. But in this case, I think that the doctor has a role, an important role, and it is ethical for him to try to convince the lady to tell her siblings and brother about her genetic problem. So she might save some people from her family, and she have to make her understand that this is not, c'est pas honteux, the word. He will consider it's honteux to have a genetic disease.
So you cannot bypass her wish.
Exact. We cannot. Now, if she doesn't want by herself to tell her family, the doctor can help and be a person who can talk to the other persons, but with the permission of the patient, because of the confidentiality, which is very to be respected to the end. We can never divulge any medical information concerning a patient to a third party, even if it is the family. So I think that we have to respect, as it is here, we cannot disclose the information to third party. We have to respect the patient confidentiality, but we have to do all the effort to convince the patient to discuss with her family, or the doctor can do the job and discuss about that. So for the yes, there is a problem of telling or not telling. In the mind of the patient, the first reaction is always not to tell anybody about her situation and disease. But I think that we have a good role to make it more easy for the patient and convince him that it is better in the benefit of all people to discuss the situation with the family. We can discuss, yes. The second situation is about the testing of children. We know that we don't test children under the age of 18 or the majority in general, because there is no risk before the age of majority to have a cancer. But in this case, we have a lady with 8 years. We should convince Samar not to do a genetic test for her 8-year girl. The 15, no. Maybe the 18 years, because the lady start to be very, aware about the situation. We can talk and counsel her about the situation, and start at 25 years the program of screening about breast cancer. So the last scene is, assume that Samar's sister, which is Sulaima, who goes to the same family physician and has applied for health insurance. She is unaware that her sister had the BRCA mutation. The insurance has asked the family doctor, with the family doctor of the family, to provide relevant medical information. Is the family doctor morally obliged to provide the information he knows about this family? There is a dilemma, because in the contract with this is a doctor who is paid by the insurance, to select the patient for the best care of the insurance. How can he deal with what he has signed and not telling, putting the report about Sulaima's risk of having.
Well, it goes to the patient much more than the insurance company.
Okay. Should he resign? No, I'm asking. He cannot do the report, and in the same time, he is tied by his contract with the insurance.
Yeah.
What is the solution?
But the patient
He can ignore. He can ignore that he knows about her sister. This is what you want to say. Anyway, I find that there is a dilemma here between a doctor who is tied by his work and the confidentiality of the patient. The best way is to find a way that people who have genetic diseases doesn't have to be affected by insurance companies or by employment or whatsoever. And this is what was done in the United States. In 2008, there was a law in the United States, which we call it Genetic Information and Non-Discrimination Act. And in this act, it is prohibited for insurance companies and employers from discriminations on the basis of information from genetic tests. This, when you have a law, the patient is protected and there is no discrimination about the fact that they have a genetic test. I think that we need to have somehow some act like this, or we can, in general, when we have internationally a consensus about a situation, like it starts in the United States or in Europe or somewhere, we try to do some similar law in our countries so that we can protect our people from discrimination when we have genetic tests. And in this situation, I think that in Lebanon, what you can do, you can say there is a law and a consensus in the world that we don't do any discrimination of people who have genetic diseases, and to use this against them in insurance companies and other things. And they in the law, they don't allow people and companies to request or demand a genetic test. It is forbidden to ask the test. And if a person have a positive test, they should not take the decision concerning the positivity of the test, and no discrimination about that. Here, where the application in genetic testing can be can affect the person in employment, education, in insurance, in criminal justice system, as a excuse or sentencing. But in some countries, genetic test can be used for forensic reason, and in this case we have a law. In our countries we have a law when we do a genetic test, and this should be asked by a judge, by النيابة العامة to ask for the test, and it is always for a forensic reason and for asked by the law of the country. And in Lebanon, we have this 625. You have to keep it in mind. In 2004, the National Ethics Committee has provided the terms of this law in Lebanon, and it was signed at that time, and it is effective in Lebanon about how to deal with the genetic testing and the protection of the genome, and how we deal with the data that is obtained in the laboratories or somewhere about genetic tests. It is interesting to read about it. And this is one of the first act of the Lebanese National Committee for Ethics that they contribute to the publication of this law. And we are working to educate people and to diffuse the information in the country and to put it in the undergraduate program of ethics in our universities. And we ask you to eventually to take information about it. It's very easy to obtain. بس تحطوا law 625 in Lebanon, you can have the details of the deal. I thank you very much for it.
Thank you, very important. Genetics. So we aim to get out with this is very important. So let's do this.
So we're arriving at the end of this meeting. Thank you for everyone. You have made this meeting a success. It is the 11th rest days that are being concluded. Hopefully we see you in Algeria next year for the 12th day. And really I thank our visitors who came from abroad because of the very difficult situation. They insisted to come, and they are really courageous. Now unfortunately, our Egyptian colleague had their flight that are delayed a few hours, so Middle East is canceling flights. So their flight are delayed about 6 hours. So even though they are at home, they are here, you are with us, and you'll be always the most welcome. Thank you for everyone. And I would like to ask Severine to give a last word. Unfortunately, Severine couldn't be here because of the same reason, and it's understandable. She wanted to say a last word as secretary of the association. Severine, I give you the last word.
Ok, vous m'entendez? Donc, merci David de me laisser les mots de conclusion. Donc, au nom d'Astarté, je suis infiniment désolée de ne pas être avec vous et c'est effectivement beaucoup plus vivant d'être en présentiel. Je voudrais juste voilà, ouvrir sur quelques mots. Finalement, du dépistage à la génétique et à l'immunothérapie, il y a une mer Méditerranée à traverser. Je pense voilà, que la cancérologie est un programme politique collectif qui rassemble bien sûr toutes nos spécialités ici présentes aujourd'hui et tous les citoyens de nos pays. Les coûts de nos traitements dus aux examens diagnostiques et aux innovations et à l'imagerie est une réalité de terrain. Je pense que ne nous leurrons pas en Méditerranée, comme j'en parlais hier avec Assad, il y a des disparités immenses dans l'accès aux soins, au diagnostic, au traitement. Une journée comme celle-ci montre que nous, médecins, grâce à nos tissus associatifs comme Astarté, à des volontés individuelles, et je pense à toi bien sûr David, à Anas, à Véronique, à Yasser, à Assad et à toutes nos institutions, il est possible d'agir donc pour la santé des femmes et donc de la société. Je voudrais terminer en disant que nos internes, c'est-à-dire toute notre jeune génération, sont nos passerelles entre nos territoires, nos cultures, et nos jeunes générations sont là. Le docteur Iman El-Feghali les a représentés d'une manière remarquable ce matin. Je pense aussi à Cyril et à tous nos internes libanais qui sont dans notre hôpital Saint-Joseph, à des internes italiens aussi qui viennent, des internes de Pologne, des internes, donc c'est par les internes que l'espoir d'une santé partagée en Méditerranée demeure et une association comme Astarté peut porter cette voie. Il y a encore beaucoup de chemin à faire et je pense qu'on doit encore inventer de nouvelles façons peut-être de communiquer, de traiter et de prendre soin de la santé des femmes à travers peut-être la santé des seins. Je vous remercie infiniment pour cette organisation et David pour le travail colossal que ça a été jusqu'au bout.
عامل ريكوردينج لأنه أنا في هيدا بس بدي أطلعه تبع لأنه فرض منه هلا بشوف فوق أليو هذا لمين وهيدا
Thank you very much. Very
ليك بص الو، ليك هون في لابتوبين هون، في واحد على الخشبة، في واحد على الخشبة، في فوق، في واحد تحت على هيدا على المقعد شمال، واحد ممدوح. اوكي
يعني صار
مفتوح باسم هôtel-Dieu de France، أنف وقت HDM هي تبعهم. ايه مظبوط مظبوط. طبعا لوك اوت يعني قصدك ساين اوت. ايه ما هي الادج مفتوحة، مفتوح بقلب تيمز تبع الانفو. اوكي بعمل له ساين اوت هذا عادي، ما في ريكوردينج. مظبوط مفتوح برا مفتوح ما يلا مفتوح تيمز على الادج. اوكي بس ما في شيء عم يعمل ريكوردينج، ما في شيء عم يعمل ريكوردينج. في كم برا مكتوب
يعني اسمع شو قول شو هو الشحاله بالدوران والله بس لا يعني هيفهم ناصر
مظبوط لك. لكن هيدا هون هذا التيمز هون
هون شو بدي مربع تسكر كل شيء هون اخر همه.
هون بسكر كل شيء. لك ريكوردينج، هذا الريكوردينج، هذا الريكوردينج. كلهم برا كلهم برا كلهم برا. ليف